Hello everyone. Today we'll discuss about apnea of prematurity. So starting off with its definitions, here we have two terminologies. That is, one is apnea and another one is periodic breathing. This periodic breathing is most common in preterm infants. So it occurs normally in preterm infants. So this is, the child will have a normal respiratory cycle, that is a regular respiratory cycle with intermittent respiratory pauses will be present. So the child can experience more than or equal to 3 respiratory pauses during its respiratory cycle. This respiratory pause, the duration of this pause will be more than 3-second duration. That is may last for even for up to 5 to 10 seconds. So the duration will be greater than 3 seconds. This can last for at least last for 5 to 10 seconds in duration. So while there is a respiratory pauses in the child's respiratory cycle, while the child is breathing, there won't be any vital changes. Its heart rate and the saturation will be maintained. There won't be significant changes in its vitals. Okay, this is the periodic breathing. This is called as periodic breathing. That is a normal breathing, normal respiratory cycle in a preterm infants will have this respiratory pauses which is not associated with any vital changes. The duration of this respiratory pause can last for up to 10 seconds. Okay, this is about periodic breathing. While you come to apnea, this is a cessation of an airflow. The child will not have an airflow inside the lungs. So it is a pathological cessation of airflow. This airflow or this pathological cessation of breathing, this lasts for about duration. Next point will be, or key point will be, your duration for how long? For longer than 20 seconds. Then you call it as apnea. So the child will have a cessation of breathing for up till more than 20 seconds or lesser duration. Or for lesser duration when it is associated with significant bradycardia and or significant hypoxemia. The significant hypoxemia, you can see the changes in the child skin color change. Okay, so there's a pathological cessation of breathing for more than 20 seconds or for lesser duration with significant bradycardia and significant hypoxemia. When do you call it as a significant bradycardia? When the child's heart rate is less than 80 beats per minute, you call it as significant bradycardia. Next, significant hypoxia, when the saturation, that is oxygen saturation, is less than 80%. So you have to remember the number 80. So significant bradycardia is less than 80 beats per minute and significant hypoxemia is saturation of less than 80%. Okay, next definition. Coming off to next definition, persistent apnea. So what do you mean by persistent apnea? When the apnea continues beyond 37 weeks of post-menstrual age, then you call it as persistent apnea. So that is an apnea continuing beyond 37 weeks of post-menstrual age, then you call it as persistent apnea. So these are the few definitions you have to know. Next, we'll go on to its incidence. So this incidence of apnea of prematurity is inversely proportional to the gestational age. So the incidence is always inversely proportional to gestational age. So there will be a 20% of infants at a gestational age of 34 weeks will have this apnea of prematurity, while infants at a gestational age of 28 weeks it will be 80%. So there will be 80% of infants when this gestational age is 28 weeks can experience this apnea of prematurity. So incidence is always inversely proportional to the gestational age. This apnea is mainly related to the immaturity of its respiratory system. So only their incidence is inversely proportional. So it is related to immaturity of respiratory system. Okay, we have 3 types here in apnea. First one is central apnea. Second one is obstructive apnea. Third one is mixed apnea. These are classified according to the inspiratory efforts. Okay, so the most common type among this is mixed apnea. Mixed apnea is the most common one, which is accounting for about 50%. Next type, that is second common type, is central apnea, which is accounting for about 40%, and obstructive is 10%. It can cause 10% of apnea. So we have difference in the central, obstructive and mixed apnea based on its airflow and chest wall motion. The airflow will be absent in all the 3 apnea. So apnea meaning there's a cessation of airflow. So when the airflow is stopped, so there will be an absence of airflow in this all the 3 apnea. And we'll talk about the chest wall motion. In central apnea, the child will not have a signal from the CNS, that is from the brain, to the lungs or the chest wall muscles and to the diaphragm. The child will not get any signal from the brain to the muscles of the chest wall and the diaphragm. So the chest wall movement will be absent here. Okay. While in obstructive apnea, this is mainly related to this upper airways. So mainly because of the in preterm child, the tone of the pharynx will be very less. So that can cause a compression. Neck flexion can cause the obstruction, or some secretions can cause obstruction, or the chest wall movement or the chest wall itself will be very highly compliant and flail. So this all the causes of, I'll tell you the pathogenesis later. So this all can cause obstruction, but the signal from the CNS or the signal from the brain will be present to the child. So the chest wall movement will be present here. Okay, so this is about obstructive. While in mixed apnea, initially there will be no chest wall motion, then there will be a minimal chest wall motion. So initially it will be like central apnea. So initially the child will have a no chest wall motion, then a signal from brain will come to this chest wall or the respiratory muscles and the diaphragm, and there will be a minimal followed by a minimal chest wall motion. But during this all the time, that is initial with no chest wall motion and going on with a minimal chest wall motion, during this all the time there won't be airflow. There will be a cessation of airflow, because while the child is having a minimal chest wall motion, this obstructive apnea can take place. So there can be some obstruction in this upper airway leading to cessation of airflow. Okay, this is about the types of this apnea. Next we'll think about pathogenesis. So first we'll talk about pathogenesis of central apnea. So pathogenesis of central apnea is, first one is mainly because of developmental immaturity of central respiratory drive. So there will be a developmental immaturity. I am not going into the detail of the pathogenesis. I am just telling you the few points that you can mention in your examination paper. So it's the developmental immaturity of central respiratory drive. Second one is this chemoreceptors. So chemoreceptors, that is present, there is peripheral chemoreceptors and central chemoreceptors you will have. So peripheral chemoreceptors, it is present in the carotid body and in the aortic body, which will be immature. So there will be an immaturity of this peripheral chemoreceptors, that is leading to a signal delay. Okay. Next, third one is the child in its sleep state. When the child is in a sleep state, this REM sleep, when the child is mainly in this REM sleep, there will be a irregularity in the breathing. So there will be irregularity of the tidal volume and the frequency of respiration. So there will be a irregularity of the tidal volume and respiratory frequency. Okay, so the child will experience apneic spells during this REM sleep. Okay, but here in preterm infants will have a majority of the sleep. So majority of the sleep duration is predominated by the REM sleep. In preterm infants, the REM sleep predominates. So since the REM sleep predominates in this preterm infants, this apneic spells will occur most frequently. So you can write this REM sleep in the pathogenesis of the central apnea. Next cause will be hypercapnic. There will be an impaired hypercapnic ventilatory response. So there will be an impaired hypercapnic ventilatory response. So when there is, what is the meaning of this impaired hypercapnic ventilatory responses? The preterm infants, they will have the threshold for this carbon dioxide just below the normal baseline. So I will write it here. So the threshold for the carbon dioxide. So the threshold for this carbon dioxide will be just below the normal baseline. So when it is just below the normal baseline, even if they have a brief period of this hyperventilation, so when they have this transient, so they'll be experiencing only a transient hyperventilation. So when they experience this transient hyperventilation, there will be whole washout of this carbon dioxide, that is leading on to trigger the apneic episodes. Okay, so why? Because the threshold is for the carbon dioxide is just below the normal baseline in preterm infants. So these are some pathogenic mechanism involved in the central apnea. Next we'll see the pathogenesis for obstructive apnea. So the pathogenesis involved in this obstructive apnea, as I have told earlier, one is pharyngeal obstruction. So why? Because pharynx is the most collapsible portion of this upper airway, leading on to this pharyngeal obstruction. Next is neck flexion. So that can interfere with the patency of pharyngeal muscles. Plus the child is having a poor muscle tone, that can lead to the obstruction. Next is nasal obstruction, can even cause this obstructive apnea. Nasal obstruction can be due to secretions or due to the nasogastric tube in it. So you prefer orogastric tube instead of this NG tube. Next is the chest wall. The chest wall will be highly compliant and it lacks stability. It is highly compliant and lacks stability. So these are the pathogenesis involved in the central and obstructive apnea. Next, if the apnea occurs, next point here is, if the apnea occurs in first 24 hours or beyond 7 days of life, are likely due to the secondary causes of, okay. So when the apnea, I'll write it here, when the apnea occurs in first 24 hours or beyond 7 days of life, it is mainly due to secondary causes. So what are the secondary causes? So next we'll see the secondary causes that are causing the apnea. Because apnea of prematurity is a exclusion term. Only when you don't find the causes for the apnea, then you term the child as having an apnea of prematurity. If you have a cause, you have to treat the cause only. So the cause is starting with temperature instability, that is both hyperthermia, both can cause apnea. Next one, starting from the head, that is neurological causes that can cause apnea are intracranial infection, next intracranial hemorrhage, seizures, and perinatal asphyxia. And the child had a perinatal asphyxia, the child can experience this apnea. Next, after neurology, you come to respiratory system. In respiratory, the child with respiratory distress syndrome, pneumonia, pulmonary hemorrhage, obstructive airway lesions. When the child have an obstructive airway lesions like laryngomalacia, the child can experience this apnea. Or when the child has pneumothorax, when the child goes in for spontaneous pneumothorax, the child can experience apnea. Next, coming to cardiac cause. Cardiac cause can be congenital heart disease, PDA, congestive heart failure. Okay. Fifth, come to GI. In gastrointestinal, when the child has a necrotizing enterocolitis, or when the child experiences GERD. These are contributory factors to apnea. Next, going on to the hematological causes. Hematological both way. Anemia can also cause apnea, and polycythemia can also cause apnea. Seventh, infections, that is sepsis, pneumonia, meningitis, necrotizing enterocolitis can everything lead to apnea. Next, metabolic causes. So metabolic causes like hypoglycemia, hypocalcemia, hyponatremia, and hypernatremia, everything can lead to apnea of apnea. Cause apnea in this preterm child, or even it can cause apnea in the term child. So apnea, when it is occurring in a term or a near term child, it is always an abnormal one, and you have to identify the causes for apnea that is occurring in the term or a near term child. Okay. Next, we'll go on to its management, the immediate management. So what will you do? You have to look for any airway obstruction. So look for airway obstruction, then keep the neck slightly extended. So keep the neck slightly extended. If there is secretions, if you find secretions, do not do a vigorous suctioning. You have to do a gentle suctioning should be done. Okay. Next, provide a tactile stimulation to the baby. You should not beat the baby, you just provide a tactile stimulation to the baby. Fourth, when you find a desaturation, or when you find that the tactile stimulation is not helping the baby, then you have to initiate positive pressure ventilation should be initiated. But while you are using this positive pressure ventilation, you have to use the same FiO2 as the baby was previously during this before this apneic episode. Okay, so you have to use the same FiO2. No need to increase the FiO2 range. Even in the positive pressure ventilation, the child is not improving, then we will go for this mechanical ventilation. So this is the immediate management. Next, how we are going to prevent this apnea? What are you going to start? You have to maintain normothermia in this child. So that is main, because temperature instability can also cause apnea. So you have to maintain normothermia by using servo controlled mode. Second, you have to positioning. In position, the head and neck should be in a neutral position or should be slightly extended. So head and neck should be can be in a neutral position or a slightly extended one. Third, feeding. Feeding can be done through orogastric way and not through nasogastric way. Fourth, the suctioning should not be vigorous. So avoid vigorous suctioning. Okay. These are the main methods. What is the drug you are going to use to the child who is having apnea? So you can use methylxanthines, that is caffeines. In methylxanthines, we'll see about the methylxanthines detailing. So methylxanthines are a mainstay of pharmacotherapy for child with apnea of prematurity. They are mechanism of action. Its mechanism of action is a competitive antagonism of adenosine receptor. So it is a competitive antagonism of adenosine receptor. This adenosine. So what does this adenosine do? Actually, this adenosine will cause a respiratory depression. This adenosine can cause respiratory depression. So, well, there is an antagonism of this adenosine. The child will not experience any respiratory depression. Okay. Next. So, because of this mechanism, there will be an improved carbon dioxide sensitivity. Third, there will be a decrease in hypoxic depression. So, there will be a reduced hypoxic depression of breathing. Fourth, there will be a reduction in this periodic breathing episodes. Fifth, there will be decrease in the ventilatory days. So the ventilation, the child in mechanical ventilation, the days can be reduced when we give this methylxanthines. In methylxanthines, we have, I'll write it here. In methylxanthines, we have two groups. One is caffeine. Another one is aminophylline. So what are the main differences between this caffeine and aminophylline? So their efficacy, we'll talk about its efficacy. Next, its side effects, administration, and therapeutic level. So efficacy is same. So efficacy is same for both. Side effects are less severe compared, when caffeine, the side effects are less severe compared to this aminophylline. Administration wise, it's a once daily administration, while aminophylline is thrice daily administration. The therapeutic level here is 8 to 20 microgram per ml, while in aminophylline it's 5 to 10 microgram per ml. So this caffeine has a broad therapeutic range, while aminophylline has a narrow therapeutic range. Okay, this is the main difference between caffeine and aminophylline. So we mainly use caffeine. So we mainly use caffeine here. So what is the loading dose? This is loading dose. So loading dose is 20 mg per kg of caffeine citrate. When you use a caffeine citrate, the loading dose is 20 mg per kg. You have to see the this vial carefully, whether you are using caffeine citrate or some other thing. While when you give a per oral administration, it is 10 mg per kg of caffeine alkaloid. So the dose here you have to remember is mainly this 10 mg per kg of caffeine base. So caffeine base you administer, this is 10 mg per kg. When you go for caffeine citrate, it is 20 mg per kg. Okay. Next, the efficacy of oral and IV administration both are same. Since the child will be sick or the child cannot feed in the preterm things, so we mainly go for IV loading dose. But efficacy between IV and per oral is same. The bioavailability of per oral administration is 100%. You remember that. Next, maintenance dose. So maintenance dose, you will administer this maintenance dose 24 hours after the loading dose. This is administered 24 hours after the loading dose. The dosage is 5 to 10 mg per kg once daily of caffeine citrate. Okay. Okay. So this is the maintenance dose. It is administered once daily. So even after giving this loading dose and the maintenance dose, if the baby still has apnea, If the baby still presents with apnea, what to do? You can increase the dosage of the maintenance, or you can give an additional dose. So you can give an additional dose of 10 mg per kg of caffeine citrate can be given in this child. So you can increase the maintenance dose by 20%. So you can increase the maintenance dose by 20%. Next, so this is, you have learnt about the mechanism of action, loading dose, maintenance dose, and additional doses. How long you are going to give this caffeine to the child? So this is given till 34 weeks. This is given till 34 weeks of post-menstrual age. Next, this caffeine is stopped if there is no episodes of apnea. Okay, it is stopped if there is no episodes of apnea. Then you can discharge the child only after 7 days. So discharge the baby only after 7 days of stopping this caffeine. Why? Because this caffeine has a half-life of 5 to 7 days. So it has a longer half-life. This caffeine or this aminophylline, both, they have a longer half-life. So once after stopping this caffeine, you have to observe the baby in your NICU unit for up to 7 days. After that only, if the child doesn't have any further episode, then you can discharge the child. Okay, so this is about the caffeine. Next, what are you after giving caffeine? You have given this caffeine loading dose, maintenance dose, then you have to see the FiO2 of the child, no? So how is it maintaining? Or you have to can keep the child in CPAP. I've told you can give positive pressure ventilation. Why we are using CPAP? It is because this positive pressure ventilation can cause a splinting open of the upper airways. So this can cause splinting open of upper airways by the positive airway pressure. So we use this CPAP. Even if the child goes in for apnea while the child is in this CPAP, then you use this nasal intermittent positive pressure ventilation can be used, because this can improve the patency of upper airway by creating intermittently elevated pharyngeal pressure. So here you can use nasal intermittent positive pressure ventilation. Even if the child doesn't tolerate this, then you go for mechanical ventilation. In mechanical ventilation, the settings should be a minimal settings, because the child doesn't have any underlying pathology. So you have to use a minimal settings. So mechanical ventilation with minimal settings. So this is about the apnea of prematurity. You take a glance in AIMS protocol. They have given a flow chart. They have given an algorithm for this apnea of prematurity. Just go through that also. And thank you. Next video we'll go in for some other topic in CNS. Okay, we'll go for a CNS topic in the next video. And thank you. Let's all learn pediatric together. Please like, share, and subscribe our YouTube channel. Thank you.